This session right away, and I'm very happy to see Praveen and Gopal chairing with me. The essence of this session is basically NAMD, because NAMD, all of us have been managing from the time of lasers actually. And at that time, honestly, when I had just become a consultant in RP Center, we hardly had any treatments available. But today is an era of magic, I should say, that so many options are available. Hello, can we, Madhu, sit down or? So, so this era is of anti-VEGF. You see, even in this Congress, out of 532 sessions, there are more than double-digit numbers of anti-VEGF. And I'm sure Chaitra and all must be speaking anti-VEGF at least 3-4 sessions. One of the most sought-after speakers. So in any case, what I was going to say was, it's a fashion now. But the only thing is, you see, I did one talk where use and abuse also. Because a lot of people indiscriminately also use. We will not talk about that. What we are going to talk is how it is evolving, because I like to classify VEGF into first generation, second generation. All of us started with Macugen. Macugen, I thought, was water only. There hardly any effect because the graph was always down. Then came Ranibizumab, then Aflibercept. And a lot of biosimilars are now coming up. So for the first time, graph started going up. Patients were so happy. And so now patients are happy. All these drugs are doing very well. The question is of compliance. Patients of compliance that they miss out. Once they improve, they will sit down. They may not come. You see, insurance penetration not very high, so people have to pay. So just to avoid cost, by Dr. Saab ne bulaya, they will not go. You see, in US and other developed countries, somebody will ring you up. Today is your day, or tomorrow is your day for injection. Please come. But here, no. So then is the need for longer duration acting agents. So therefore, drugs which can work for at least 3 months, 4 months, or so that if a drug is given less often, compliance definitely improves, because he may not have to, not only injection per se is a psychological. You imagine yourself lying down and ek prick ja raha hai, or har mahine ja raha hai, so it becomes a difficult job. So hence is this role of this particular session that first talk is from drying to durability. Drying is good, but it has to be good duration also. So we have first speaker is from, it's a virtual, Dr. CHRONOPAULUS. I have heard him before. Welcome, Dr. CHRONOPAULUS. Can you hear us?
Good morning. Yes, good morning. Can you hear me?
Yeah, I can. I hope you just listened to our introduction also. Were you there? Or?
Yes, I did. The host just let me in about 3 minutes ago. So yeah, I did hear your comments, yes.
Yeah.
I agree with them, yes.
So welcome, and we are all looking forward to your talk from one D to the other D also. You see, drying all these agents do. But the second generation of anti-VEGFs, which have come in a very big way, are promising increased duration. So I will, like to start with your talk, which is drying to durability, deep dive into with Brolucizumab. Over to you.
Yes, many thanks, dear Dr. Werner, for the invitation. To all your colleagues there, I'm really honored to be again at your meeting. Can you see my presentation well or not?
Yeah, we can see and hear also. Yeah.
Okay, excellent. All right. So my title today is From Drying to Durability. As you said before, the drugs work, but they also need to give us a sustainable result. That's why I'm here to talk about today, the necessary disclaimer, as you can see. So when we're asking ourselves what's in the future and what do we need from the new drugs, we always think about having drugs, as you said, that they're more durable, that they work faster, and they can provide with patients with a nice results for the next months with a stable vision and stable retina. And I always like to look at the path surveys that actually show what all the colleagues, not only in the USA, but also internationally, think and want for the treatment. And if you take a look, 2023, 2024, The major results, they don't differ that much. Most of the colics, they need a longer maintenance of dryness, and they need a better long-term visual outcomes. That's the same for 2023 and 2024. Why is that? Well, you know from the fact and from the practical experience that there is an unmet need, not only in AMD, but in other cases, but particularly in AMD, we have patients that are older, and we have adherence issues. We have a treatment burden that's unmet. We have suboptimal dosing, so it means the patient comes back in, we change the drug, etc. So all these things, they lead to a worse compliance, and at the end, at the non-adherence. So all this sums up to a worse result for the patients. So we need a maximum sustainable vision with less injections if that would be possible. Is it so? Is it so from what we have seen so far from the registration trials and from the randomized controlled clinical trials in the real world? Yes, actually, that's the answer, because if you take a look here, this is a summary of all studies so far. In the right-hand side, we have the real-world evidence, and in the left-hand side, we have the randomized clinical trials, and we struggle to bring the left-hand side, the right-hand side to the left-hand side, where everything is controlled and we have a maximum result of the drug, whereas in the real world, we don't see the result. There are a couple of reasons for that, but this is the the reality so far. 3 years ago, have since 3 years now, we have the third generation of anti-VEGF, and the one of the latest molecules that we have in our pipeline is the Brolucizumab. It's on the right-hand side of this table, and if you see, this is a very extremely small molecule. These are only the single-chain antibody fragments of this antibody. It has a molecular weight of 26 kilodalton, which is extremely small, and this makes it easy for a higher molar concentration, and it was designed that way to penetrate the retina in a very efficient way. And we know from the Hawk and the Harrier studies, with work conducted for AMD patients, that the Brolucizumab is drying the retina much faster than the comparator. We have better percentages as far as the macula is dry, and we have even less patients that have intraretinal fluid and subretinal fluid. If you take a look at these curves, the gray curve is the comparator, and the light and the darker blue curves are the the Brolucizumab. You see how much smoother and faster the drug is drying the retina. And not only that, you don't have that much of volatility. I drew a red line to make it a little bit more understandable. You don't have that much of volatility in the retina, which is actually very good, because you keep the tissue quite calm and dry. You have less fluctuations, and that's actually one of the things that we do really need. And has it paid off? Yes, it has. In the registration trial, you see that the darker curve, which is the highest, is the Brolucizumab, and it reaches the desirable result in much faster way with less injections. That was as far as the registration trial is concerned. What about the real life? 2023, we saw this retrospective study, which was actually a registry analysis, and it gives us a first estimate of how this drug is working. And currently, at least 2023, the reality is such that it shows that the shift is towards the treat and extend, which means that we have now the option to a higher percentage of patients, it's almost 90% of patients, to extend the treatment plus 2 weeks, and almost a little bit more than half of the patients at this cohort, at this registry, they were extendable up to 4 weeks. And this is one of the things that these new drugs can really do. What comes from Germany? This is a study, the Blue Sky study. I'm not sure that you have heard of it, but this is a stress test, so to say, for the Brolucizumab. This is actually the real world data as it shows in Germany. We had 542 patients with NAMD that were tested until the end of 2023. This was a 24 months trial, like 2 years. Currently, we have the interim data, which were 12 months. This was a prospective multi-center one-arm phase 4 study. And we included actually all of the patients. We included both treatment-naive patients and pre-treated patients. They had a certain history of pre-treatment with other drugs. But both treatment-naive and pre-treated patients, they were included in this study. Of course, the endpoints were evaluation of fluid reduction, anatomic effect, vision, and of course, ANEs. If you take a look here, both of the groups, the treatment-naive groups and the pre-treated groups, they were more or less similar. And basically, the indication, the pre-treatment groups were a little bit higher, 61%, and the therapy treatment naive were about 40%. Most of the patients, the pre-treatment group, they had a history of about plus 10 injections, more or less. And the reasons to switch, they were distributed amongst functional reasons, which means that the patient were not responding very well as far as the function is concerned. We had a vast majority of anatomical issues like IRF and SRF, things that we're struggling with every day. And some patients, about 26%, they wanted to extend the treatment intervals. So did it work? Yes, it did. It did. In the treatment naive and in the pre-treated group, we had a robust reduction of the intraretinal fluid. You can take a look at these both graphs. Of course, the treatment naive patients, they had a more robust reduction because they had no treatment before. The second group was the pre-treated ones. They also gained from the treatment a little bit lower because the eyes were pre-treated. This is as far as the intraretinal fluid is concerned, but exactly the same we saw in the groups in the subretinal fluid. There was a robust reduction of the fluid also in this parameter. What about the course of the CMT? And that's one of the things that's very, very important. You see, up to month 12, we had a stable reduction of the fluid. It speaks for a sustainability of the drug. What about the course of vision? You can take a look here. Depending on how the patients start the treatment, they also gain, and they gain sustainably. One of the most things that actually, for me, it's very important to see is that all of the groups and all the patients stratified in different groups, they do gain. But if you have somebody and you're thinking of starting the treatment or not, it's better to start fast because the patients that had a good vision from the beginning, they can maintain their vision up to 12 months. So it means that you don't hesitate. Start with the drug to have a good and sustainable result at the end. What about the sustainability and the flexibility of the treatment? Indeed, also in this area, there were major gains to see. As I said before, we had the treatment naive and the pre-treated group. And one of the things that came out very nicely is the fact that the treatment naive patients, they gained almost 25%. They went up almost up to 80%. The vast majority of this group, they could extend it they could actually be treated well with a treat and extend regime. And what does it practically mean? We had, for the treatment naive groups, we have up to 12 months. We had 8 injections in 5 visits. And sorry, the other way around. We had 3 injections at the beginning, and we have 3 injections at the end. We have 6 injections in 8 meetings. And the same more or less thing is also true for the pre-treated group. So we go down with the injections, and we also go down with the visits. Now, one of the most important things as far as Brolucizumab is concerned, because there was a little bit drama at the beginning of the launch of the drug, is what's happening with the ANEs. And from this cohort of patients, we had a very small number of vasculitis and retinal vein occlusion. That was Brolucizumab-associated ANEs. It was very interesting to see that also the other ones of the ANEs, there was also very low represented, which speaks actually for a very good tolerability of the drug. Now, we also did locally, we analyzed some patients. I don't really want to go into the details of the study. What I really want to show that the drug is really working. We had patients pre-treated and not pre-treated. It really works for the vision. It really works for the retina. But one of the things that really interested me from the beginning is take a look at this patient. This is a 58-year-old male patient with an AMD treated since 2026. Once we saw him in the consultation, we saw an extensive area of pigment epitheliopathy with subretinal fluid. It obviously hasn't responded to bevacizumab or sub-responded to bevacizumab, aflibercept. He also had a PDT in the past, and we opted to switch the patient to brolucizumab. And what you know, take a look at this area. The subretinal, the neovascular membrane goes away or gets very, very small, attenuated. And this is a very nice result. On the right-hand side, the subretinal fluid is gone after 3 injections of brolucizumab. There's one more interesting case of a patient that came in 2022. At that point, he had a very good vision. It was almost 100%. If you take a look, he has a very subtle alteration of the on the pigment epithelium, which could be at that point, which have been at that point a very premature NAMD. He came back 2 years later with a macular bleed. We treated him with corvitrectomy, TPA, and bevacizumab, and gas. And in the next course, he received bevacizumab on a monthly basis, and you see that the retina is not responding. Until we made the decision, it was mid of January 2025, to switch him over to brolucizumab, and take a look how he has evolved so far. This is a nice case that came right out of the consultation. You see how smoothly the retina goes down and how smooth the vascular membrane is getting smaller. We also had we have also examined this drug in another cohorts with AMD and pigment epithelial detachment. That was from the beginning a very interesting subcohort of patients to apply the drug to. This has already been published. This is one of very impressive images where you see the patient on the left-hand side. He comes in the consultation with an extensive PED, a subretinal fluid. The patient starts the treatment with anti-VEGF, which is not working that really well. You see it in the middle panel. You see the pigment epithelial detachment is still there. You see the subretinal fluid is still there. And at that moment, in the middle panel, we made the decision to change him over to brolucizumab. And take a look on the right-hand side. You see how smoothly the pigment epithelial detachment is getting smaller and the subretinal fluid is disappearing. One more study from Germany. This was I think the very first one, at least in the European area. This is the REBEL study, a real-world study of brolucizumab. They had 78 consecutive patients examined with 105 eyes, both treatment naive and treatment switch patients. Both of the groups, they did gain in vision, plus almost 12 letters in the treatment naive group and plus 10 letters in the therapy switch. If you wonder about the ANEs, they only had one patient of a switch treatment that responded with a vascular occlusion, and he did actually quite well at the end of the study. This is one very interesting and representative case, as is shown in the publication. The panel D shows the state before anti-VEGF. The panel E shows the state post aflibercept and ranibizumab. You see how the pigment epithelial detachment is going up. You see a little bit of subretinal fluid, and the decision of the colleagues to change him to brolucizumab, how smoothly the pigment epithelial detachment gets away and subretinal fluid is also getting away, and how smoothly the retina goes down. One more study from Germany. This was the same REBA study as an extension. It goes up to 24 months. They also had exactly the same treatment protocol, treatment naive group and switch treatment. Both of the groups, they gain vision, plus 9 letters and plus 7 letters. And the retina went down smoothly anatomically for both groups, treatment naive and switch treatment. And they only had, from the 91 patients, they only have 5 significant unwanted events in their cohort. So as a take-home message from all this data that we have seen so far, brolucizumab is really working. It's very effective in stabilizing the retina and gives a sustainable result. It's a very small molecule. That's why it's working so good. It has been designed that way to give a higher molar concentration and penetrate the retina in a very good way. It is the only drug so far that has the fastest SRF resolution, and it leads to improvement of the vision and sustainable results. Many, many thanks for listening to me.
Thank you,